Hey everyone, this is Dr. Medicine RX and in today's video we'll be discussing about dermatomyositis. So it is an IIM, which is an idiopathic inflammatory myositis, and it is characterized by muscle weakness and cutaneous eruption. Coming to epidemiology, it is most common in Asians, and females are commonly affected than males. And coming to the age of onset, there is a bimodal distribution where cases can be seen in the childhood at the age of 5 to 14 years or in adulthood in the age group of 50 to 70 years. There is a strong association with internal malignancy, that is DM is usually associated with internal malignancy. In females, the common malignancies associated are breast and ovarian carcinomas, whereas in males and in overall population there is an association with lung carcinomas. Coming to the triggers, so obviously there is a genetic predisposition with some HLA factors, and then there's environmental factors such as infection with group A beta hemolytic streptococci, Coxsackie virus B, and toxoplasma. There's association with UV radiation, cancer associated myositis, that is the one we have discussed above, and certain drugs such as penicillin, statins, isoniazid, and D-penicillamine. Coming to pathogenesis, there's two proposed mechanisms of pathogenesis. One is the antibody centered and the other is the interferon pathway. However, the common pathway is going to be formation of autoantibodies and followed by endothelial damage. So the antibody centered model proposes that the triggers, as mentioned before, cause autoantibody production, which binds to the endomysial capillary endothelial cells, that is the endothelial cells present in the capillaries of the muscles, leading to vasculitis, which causes ischemia and perifascicular atrophy. Whereas the interferon pathway states that following triggers, there is sensitization of the immune system leading to interferon production, which causes T cell tissue damage and activation of the T cells and B cells, which further cause autoantibody production and which cause the endothelial cell damage. Coming to clinical features, as usual, they are divided into skin manifestations and systemic manifestations. The skin manifestations are, first is photosensitivity, and how this photosensitivity differs from that of SLE is that it is associated with pruritus and erythema that involves the face, neck, and upper chest. And the facial erythema, it is seen on the malar areas and it involves the malolabial folds and it is more violaceous. Whereas that in SLE, it involves malar areas, it spares the nasolabial folds and it is more erythematous and there is no pruritus. And then there is something called as heliotrope rash. This is something that is characteristic of dermatomyositis, and this includes erythematous lesions, rash that involves the eyelids and the periorbital areas, and there can be periorbital edema as well. And then there is something called as shawl sign, and this is the rash that involves the upper back and shoulder regions, and it is more kind of violaceous erythema, and there can be a poikilodermatous change. And then there's something called as V sign when the rash involves the V area of the neck and the upper chest, and then the Olster sign when the rash involves the hips and the lateral thighs, and Gottron's sign when the rash is seen over the joints. Coming to Gottron's papules, they are a pathognomonic of dermatomyositis, and they are flat-topped lichenoid lesions that occur over the distal interphalangeal and proximal interphalangeal joints, and as well as the metacarpophalangeal joints, and they are red or lilac color, and they can also occur over the elbows and knees. And then there is something called as inverse Gottron papules that are seen on the palmar surface of the finger creases. Then hand edema can also occur along with these rashes and papules. And then mechanics hands, which are hyperkeratotic and fissuring of the hands and sometimes also the feet, and especially it is seen over the radial surfaces of the fingers and the outer border of the feet. And the hiker's feet is the bilateral cracking, hyperkeratosis and scaling of the palmar aspects of the feet. Both mechanics hand and the hiker's feet are associated with anti-synthetase syndrome. Then cutaneous calcinosis, it is more likely to occur in juvenile dermatomyositis, and it is nothing but calcified material being deposited in the myofascial planes. Next, coming to flagellate erythema, it is multiple red macular streaks occurring over the trunk and proximal limbs, and they give the appearance of being whipped. So if someone has whipped somebody, the lesion, the erythema that occurs after the whipping kind of is similar to the flagellate erythema. Then there is also vasculopathy. And coming to the nail changes, there is periungual erythema, there can be splinter hemorrhages, and hypertrophic cuticle, which are dystrophic and ragged. Then hair changes, scalp changes include scalp erythema and sometimes even diffuse non-scarring hair loss. And other changes, other features that can occur include the seborrheic dermatitis like scaling in the seborrheic areas, panniculitis, leukocytoclastic vasculitis, erythroderma, livedo reticularis, anasarca, acquired ichthyosis, lipodystrophy, and hyperpigmentation. Coming to the systemic manifestations, so constitutional symptoms like fever, malaise, weight loss can occur, and they can also be Raynaud's phenomenon. So as the name indicates, this immune disease, it involves the muscles. So muscular manifestations is the classic slowly progressive symmetric muscular weakness. It can involve the proximal muscles as well as the truncal muscles. And patients, they complain of difficulty in climbing steps or combing hair or from getting up from sitting position. And it typically affects the shoulders, the hip girdle, and also the neck flexors. So extensors is usually more commonly affected than flexors. And also upper esophageal sphincter weakness and also oropharyngeal muscle weakness leads to dysphagia. And as a result of this, there can be aspirational pneumonia. Then joint involvement, it includes arthralgias and arthritis. It is non-erosive and non-deforming arthritis, and it is symmetrical, and it involves the small joints of hand, wrist, and also ankle. And then pulmonary manifestations, these are major cause of mortality. They can present with dry cough, dyspnea, exertional dyspnea, and even crepitations on chest auscultation. And because of respiratory muscle weakness, the patient cannot take the breaths properly, so there can be hypoventilation and aspiration pneumonia. And interstitial lung disease is also a cause of premature death in dermatomyositis. Next, coming to cardiac manifestations, there can be conductional defects, conductional abnormalities, arrhythmias, congestive heart failure, myocarditis, and secondary fibrosis. Coming to gastrointestinal manifestations, so there can be dysphagia, because there can be upper esophageal sphincter issues and oropharyngeal muscle issues, and because of this dysphagia and because also of the pharyngeal muscles involvement like we discussed. So this dysphagia, it is to liquids and solids and leading to pooling of secretions because poor palatal motion as well. And there can be nasal regurgitation of these pooled secretions, and there can be esophageal reflux and decreased intestinal motility and rectal incontinence. Coming to renal manifestations, it is usually uncommon in dermatomyositis. However, secondary to myoglobinuria, acute tubular necrosis can occur. So coming to investigations, complete blood picture, biochem profile, then muscle enzymes to detect any muscle defect. So CKMB, aldolase, LDH, SGOT, and SGPT. And serum CK is the most reliable enzyme for muscle involvement in dermatomyositis. Coming to skin biopsy, there are some non-specific findings, and there can be epidermal atrophy, there can be vacuolar degeneration of the stratum basale, and lymphocytic perivascular infiltrate with mucin deposition in dermis. And nail fold capillaroscopy, it shows enlargement of the capillary loops. There can be loss of capillaries in areas where they are normally present, and there can be bushy capillaries or capillary hemorrhages or twisted or enlarged capillaries, etc. Muscle biopsy is a gold standard investigation. It shows perifascicular atrophy. There can be muscle infarcts and necrosis. There can be loss of myofibrils and capillary necrosis, and even inflammatory infiltrate is present in the septa, around the vessels, and inside the fascicles. Then electromyography, it is sensitive for inflammatory myopathy, and it is helpful in selecting muscle for the biopsy. Coming to serology, we've got something called as myositis specific antibodies and myositis associated antibodies. So these specific antibodies, they are associated with a specific cutaneous feature like we have discussed. So these include anti-synthetase autoantibodies like anti-Jo1 and non-synthetase antibodies like anti-MI2 or even NXP2 or TIF1 gamma or alpha, or anti-MDFI, anti-SAE, anti-SUMO. And These MSAs, they are found only in inflammatory myositis or in patients with interstitial lung disease, and they are directed against the cytoplasmic proteins and RNA, and they precede the onset of myositis, and they also correlate with the activity and the remission with and they disappear with remission. So they can be helpful for understanding the disease course. And we have also got myositis associated antibodies like PMSCL, U1RNP, KURO, and U3RNP. Then imaging, MRI imaging of proximal muscles in children to see any edema or even to detect any subclinical muscle involvement. And other investigations include X-ray for calcinosis or any specific organelle involvement, lung function tests, then HRCT to detect interstitial lung disease, and then barium swallow and esophageal motility for any GI abnormalities, ECG and echo for cardiovascular abnormalities, and PET scan to detect any malignancy. Coming to treatment, for cutaneous manifestations, since there is photosensitivity, sunscreen, broad spectrum sunscreen is necessary, and topically we can use steroids and tacrolimus. Systemic drugs for skin manifestations include hydroxychloroquine and antihistamines for pruritus. Second line manifestation for second line drugs, we can go for methotrexate, mycophenolate mofetil, dapsone IV agent, rituximab. Calcinosis, we can go for bisphosphonates, calcium channel blocker like diltiazem, and even excision of the calcinosis. In case of where there is erythema, like we discussed, various signs that we have discussed, for that we can go for pulse dye laser. In refractory cases, Janus kinase inhibitors like tofacitinib can be tried. Coming to systemic drugs, so corticosteroids in a dosage of 0.5 to 1 mg per kg per day should be started, and if there is refractory or severe case, then IV methylprednisolone 500 to 1000 mg per day for first 1 to 3 days, followed by high dose oral steroids are to be tried. And adjunctive therapy is needed in refractory cases with methotrexate, azathioprine, cyclophosphamide, and cyclosporine. Methotrexate is the first choice. It can be given in oral or subcutaneous or intramuscular routes in a dosage of 7.5 to 10 mg per week, and it can be increased up to 25 mg per week. Cyclophosphamide and mycophenolate mofetil are preferred in interstitial lung disease, and similarly rituximab is also preferred in refractory cases with interstitial lung disease. And intravenous immunoglobulins are to be given in refractory cases, and exercise and physiotherapy are also of great use in juvenile dermatomyositis. Thank you. Subscribe for more.